Clostridium difficile in the adult patient by Samantha Enriquez, California State University, San Marcos, N451, Nursing Leadership and Management Laboratory. C. difficile is an anaerobic gram-positive spore forming its releasing bacillus that is transmitted among humans mainly via contact with fecal material. Colonization by C. difficile stimulates the release of toxins that injure the mucosal lining, toxins A and toxin B. It can survive for weeks to months in the environment, on surfaces, and in healthcare facilities. New hypervirulent strains of C. difficile emerging in 2002 through 2009 in North America and many parts of Europe. Patients over 65 years of age are at highest risk for CDI, especially those in long-term care facilities and hospitals. Up to 20 to 50% of adults in hospitals and long-term care facilities are carriers. This is just an image of a spore-forming anaerobic gram-positive bacillus on a color transmission electron micrograph of C. diff informing endospore. What does C. difficile do to the gut? 24 hours after exposure, cells of the colon lining are normal. 30 hours after exposure, C. diff toxins have started to damage cells, triggering inflammation and fluid buildup. 36 hours after exposure, inflamed cells burst and die. C. diff spores leave colon via diarrhea and wait their next host. Hospital-acquired infections. Control and prevention of hospital-acquired infections is a priority for hospital facilities nationwide. C. diff infections, better known as C. diff, is an antibiotic-resistant infection of the GI tract characterized by watery stools that have become one of the most common hospital-acquired infections to date. In the United States, in 2011, CDI caused an estimated 450,000 illnesses and 29,000 deaths. While other hospital-acquired infections such as MRSA are declining nationwide, CDI is actually on the rise, reaching historically high rates. The etiological agent of CDI is bacterial spores. Spores are formed as a result of the bacteria exposed to stress, where it creates a protective coating in order to survive. C. diff can lay dormant under highly acidic environments such as the human gut. C. diff spores can survive on many surfaces for up to 2 years, and many antibacterial agents used in hospitals do not kill the spores. Chlorine bleach is the only agent known to kill C. diff spores. Clinical presentations include cramping, abdominal pain with tenderness in the lower abdomen, pyrexia, mild to moderate watery diarrhea, feeling unwell, loss of appetite, dehydration, dry mouth, tachycardia, mucus-containing stool, uniquely foul-smelling stool, colitis, colonic perforation, and toxic megacolon are potential complications. Contact precautions. To protect the spread of the disease, contact precautions for symptomatic patients, placing the patient in a single room or after definitive diagnosis, sharing a room with someone else who has C. diff. Wearing gloves and a gown during contact, hand washing with soap and water before and after entering a patient's room is imperative to prevent the spread of C. diff spores. Risk factors. Antibiotic therapy is the leading risk factor for C. diff infections. Other risk factors include poor health, prolonged hospital admissions, bowel disease, use of enemas, and use of nasogastric or gastrostomy tubes, recent surgeries, use of antacids, or PPIs. They reduce stomach acidity and increase risk of infection. CDI began to cause problems in the late 1960s and 70s when broad-spectrum antibiotics became more commonly used. These antibiotics destroyed the normal bacterial flora in the gut that held C. diff in balance and caused CDI. CDI can cause diarrhea or life-threatening colitis. Infection control strategies to prevent patient-to-contact patient transmissions of C. difficile is guided by standard protocols such as contact precautions and hand hygiene for all individuals in close contact with CDI patients. Proton pump inhibitors. Gut flora and gastric pH play a role in maintaining the integrity of the gastrointestinal tract. Maintaining normal gut flora and normal acidic pH of the gastrointestinal tract are key in preventing the proliferations of C. diff. With suppressed gastric acidity of pH or above, C. diff can germinate and release toxins leading to CDI. Long hospital stays or use of broad-spectrum antibiotics, the GI flora is disturbed and the spores germinate and produce toxins that lead to CDI symptoms. Proton pump inhibitors. Proton pump inhibitors are the most widely used agents for suppression of gastric acid in patients with an erosive gastroesophageal reflux disease and erosive esophagitis. Proton pump inhibitors are the most commonly used medication for stress ulcer prophylaxis in the hospital, despite little evidence to support their use outside the intensive care unit. In 2012, February, the FDA issued a safety statement that cautioned the use of proton pump inhibitors, as there is now evidence that there is an increased risk of C. diff associated diarrhea with the use of these agents. CDI current therapies. Two most common therapies used worldwide are oral vancomycin and metronidazole. Metronidazole inhibits nucleic acid synthesis in anaerobic bacterial DNA in such a way that further protein synthesis is disabled. Vancomycin disrupts cell wall assembly in gram-positive bacteria by inhibiting the glycopeptide polymerization needed for cross-linking. Current therapies have limitations with respect to efficacy, recurrence rates, and adverse effects. SIMS, stop, isolate, monitor, and support. Stop laxative use, proton pump inhibitors, and antibiotics if possible. Isolate, full barrier for nursing, environmental cleaning, and hand hygiene. Monitor stool frequency, volume, consistency, fluid intake and output, temperature, pulse, blood pressure, respirations, and oxygen saturation. Support, assistance with personal hygiene, maintain continence, encouragement to eat and drink, skin health, and psychological support. Level of severity. Mild patients with mild disease may not require specific C. diff antibiotic treatment. If treatment is required, oral metronidazole 400 to 500 milligrams 3 times a day for 10 to 14 days is sufficient. Moderate. Patients with moderate disease should be treated with oral metronidazole 400 to 50 milligrams 3 times a day for 10 to 14 days. Oral vancomycin is not recommended, as it may lead to the development of further antibiotic resistance in the patient. Severe. Patients with severe disease should be treated with oral vancomycin 125 milligrams 4 times daily for 10 to 14 days. Fidomaxin should be considered for patients with severe disease who are considered at high risk for recurrence, such as older people who need to have other antibiotics and have multiple long-term conditions. Antibiotic use. Antibiotic use can destroy most of the flora in the bowel and create ideal conditions for C. diff to thrive. About 50% of antibiotic use is inappropriate and has been associated with poor patient outcomes, developing resistance, and increased healthcare costs. Empiric treatment of upper respiratory infections with antibiotics, when there is no real indication, needs to be considered a potential risk. Many times, upper respiratory infections have viral etiology. The most effective way to prevent CDI is to ensure the antibiotic use only when necessary. Patients who are unnecessarily exposed to antibiotics are placed at risk for serious adverse events with no clinical benefits. Hospital-acquired infection. CDI is legislatively mandated reportable disease in only 6 states. The Department of Health and Human Services agencies for healthcare research and quality include C. diff in their 5-year target to reduce healthcare-associated infections by 30%. Infection control practice, including consistent hand hygiene, adherence to contact precautions, thorough environmental cleaning, and the judicious use of antibiotics as monitored and directed by hospital stewardship programs are equally important in preventing CDI. CDI increased by 8% since 2011. Deaths attributed to CDI in the United States increased from 3,000 in 1999 to 2000 to about 14,000 in 2006 to 2007. The costs associated with CDR are about $3 billion per year. Older adults have high associated morbidity and mortality from diarrhea-associated illness, including C. diff. Older adults are more susceptible to developing diarrhea due to the aging process causing changes in the normal gut flora. Aging increases the risk of developing CDI, and 80% of cases occur in people over the age of 65. Antibiotic stewardship. The misuse of antibiotics has also contributed to the growing problem of antibiotic resistance, which has become one of the most serious and growing threats to public health. In 2009, CDC launched its More for Healthcare campaign to promote improved use of antibiotics in acute care hospitals, and in 2013, the CDC highlighted the need to improve antibiotic use as one of 4 key strategies required to address the problem of antibiotic resistance in the U.S. In 2014, CDC recommended that all acute care hospitals implement antibiotic stewardship programs. Antibiotic stewardship. Antibiotics are often started empirically in hospitalized patients while diagnostic information is being obtained. However, providers often do not revisit the selection of antibiotic after more clinical and laboratory data, including culture results, become available. Treatment guidelines for CDI urges providers to stop unnecessary antibiotics in all patients diagnosed with CDI, but this often does not occur. Patients who are unnecessarily exposed to antibiotics are placed at risk for serious adverse events with no clinical benefit. Reviewing antibiotics in patients with new diagnosis of CDI can identify opportunities to stop unnecessary antibiotics, which improve the clinical response of CDI treatment and reduces the risk of reoccurrence. Antibiotic stewardship. Assess if antibiotics are being given in a timely manner and assess compliance with hospital antibiotic use policies, such as the documentation of dose, duration, and indication of the performance of reassessments of therapy. Improving antibiotic use has a significant impact on rates of hospital onset CDI, and current challenge of CDI in hospitals makes this an important target for stewardship programs. Goal. Eliminating CDI completely is not feasible, as it would be impossible to remove all potential risk factors, especially the use of antibiotics in the healthcare setting. In Orange County in 2012, CDI rates were 15% higher than that in California in general. Despite the evidence-based measures at Hoag Hospital in Newport Beach, California, CDI rates continue to rise hospital-wide. Due to this increase, Hoag's CDI prevention strategies must be reviewed and modified to meet current EBP and decrease hospital-acquired transmissions in the future. The aim proposed plan change is to reduce the occurrence of Clostridium difficile infections hospital-wide from an average of 11.2 occurrences each month to an average of 8.4 occurrences each month, a 25% reduction by June 1, 2017. Hoag had enacted a one-watery dual algorithm for testing criteria with no specifications for testing exclusion. This essentially led to overtesting, causing unnecessary exposure to antibiotics, which can subsequently cause greater susceptibility to actual contraction of CDI and simultaneously draw attention away from other causes of diarrhea. The solution was to implement a policy that would lead to more efficient testing parameters. Effective February 1, 2017, Hoag's testing policy has changed to test for Clostridium difficile only after the third loose stool in 24 hours, excluding patients on bowel preps, patients on tube feeds, and patients with colostomy or ileostomies. As to date, it is too soon to determine if these new testing parameters will decrease the incidence of overtesting and positives. Pre-change data from Hoag Hospital from 2015 and 2016 shows a marked increase in 2016 with excessive testing. Pre-change average was 11.2, and post-change average was still to be determined, as data is not yet available. References? Thank you.